And I know we've had some national speakers this morning, but I want to let you know that we do not have to leave Georgia for talent, and that's Dr. Ed Betcher, and I really appreciate him because when I asked, he stepped up to the plate and decided to do this lecture, so I really appreciate him. He is a professor and chair of academic obstetrics and gynecology as the physician leader for women's health at Atrium Health Navicent with Mercer University in Macon, Georgia. He earned his BS at Mississippi University and his MD from the University of Mississippi as well. He has numerous accolades, including the National Faculty Award for Excellence in Education and also the Journal of Minimally Invasive Gynecology Best Reviewer Award. He has over 30 years of experience in both private practice as well as academic medicine, and was one of the earlier adopters of robotic technology in gynecologic surgery, as well as remains a leader in all forms of minimally invasive surgical techniques. He remains passionate about education for residents, students, and colleagues in MIGS. And beyond medicine, he also serves on several boards, including national and university foundation boards. So I really want to welcome to the podium Dr. Ed Betcher, and he's going to speak on fibroid updates. They ain't what they used to be.
Well, good morning. You all right? Well, it's Friday. We're at the beach. Life is good. I want to thank you all for coming out and listening to some updates on fibroids. There's been a lot that has been published in the last year alone. There was over 300 peer-reviewed articles that were, pulled up when I did my search on PubMed. That is almost 3 times as much as what was published 5 years ago. So let's start off with some disclosures, some legalese, things that we need to make sure that we share with everybody. Not everything we're going to talk about is available. Not everything that we're going to discuss, because it is, cutting edge and research, is FDA approved, and some of this is still in investigational. I don't have any official disclosures, but unofficially, I practice MIGS, so I will admit I have some bias. And then on top of that, I've been involved with research with both pharmaceutical and device, manufacturers, spoken about fibroids, things like that. But it's something I'm very passionate about, and something that I think we see all the time here in Georgia. Can talk a lot more about fibroids than we have time for, but if you want to go into any details about some of the things that we're just going to kind of skim the surface on, catch me poolside, we'll share a beverage, we'll go into further details, and we'll have some some Q&A at the end here. Okay, a few objectives. We're going to talk a little bit about pathophysiology. There's been a lot of information that we've learned about fibroids in the last several years. We're going to talk about some strategies to get the best outcomes, how we compare fibroids, with treatment options. We're going to talk about some of the latest innovations, along with their limitations, and some of the impacts that we can expect to see in the next several years as far as options to treat fibroids. There was a time, and some of us in this room practiced at this time, and some of us have heard stories about this time, but we had no idea. Why do fibroids occur? Why do patients develop fibroids? We knew it was multifactorial, but we didn't know all the factors. And we were just basically treating just symptoms. We had very few options to offer patients. It was either hormonal or non-steroidal anti-inflammatories to treat the symptoms, or we were saying, when you're done having kids, hysterectomy, get it out. If you're having problems with fibroids before then we need to take the fibroids out. And these are still validated therapies, but we've come a long ways. We've developed a lot more that's available through, advancements in minimally invasive surgery with robotics. And, although morcellation is not exactly the most friendly word for us in GYN. We've learned contained morcellation is a really good option to allow us to do a lot of these surgeries in a minimally invasive fashion. So no two fibroids are exactly alike. Just to kind of orient you here, that's the uterus, that's the fibroid. You know, patients come with all different types of fibroids. Sometimes they are submucosal, sometimes they're intramural, sometimes they're subserosal. And, you know, the surgeries that we do, not all of them are exactly alike. I jokingly say that most of my surgeries are minimally invasive, but every once in a while, you got to know to cut your losses and make a big incision. So I think a lot of y'all are familiar with the staging of fibroids. I think what's really important is that we're now looking at so many different innovative options for treatment of fibroids that we really need to pair these with not only the size of the fibroid, but also the location of the fibroid. You know, how we approach a submucosal fibroid, maybe hysteroscopically versus a intramural or subserosal fibroid laparoscopically. We need to know where these fibroids are located, and we need to have a way of communicating to each other about where these fibroids are, not only their size and how many there are. And no two patients are exactly the same. We're now more than ever into shared decision making with patients. Their goals are going to be different from person to person. And I think that we have to take that into account. It's no longer, you know, hysterectomy and that's it. But we have to realize that patients are making different decisions today than they were even 5 years ago. Some are delaying pregnancy, and because of that, they're having more issues related to fibroids. We have some that are deciding not to pursue pregnancy, and their goals may be different. They're looking more at quality of life issues. And then there are some that, you know, are now saying, hey, I was born with my uterus, I want to keep it. And so we have to take that into account if that's their preference. I think one of the things that we have to think about is our toolbox has got to expand. No longer can we just have a wrench and a screwdriver. We now need to have a full toolkit to offer patients with their fibroid management. And I think that, you know, we have to pair the right tool with the right situation. Not everything requires a hammer. And we need to make sure that, you know, we're using technology appropriately for our patients. So what about the number of manuscripts? They have just, you know, exploded. You know, we're going to talk today not only about research and not only about new technology, but one of the things that I think is most innovative is we're really starting to understand, you know, what causes fibroids. This is driving a whole new area of discussion. How may we prevent fibroids in patients and not just wait for symptoms to develop or problems to make their appearance? And this is, you know, involving a lot of new technology, both in medical management and also in surgical management. And I think that, you know, some of what we're going to discuss today is going to look at data, how one treatment option compares to another. We're going to also be talking a little bit about, you know, some new technology that allow us to preserve uteruses for patients throughout their life. So 10 years ago, we thought we were pretty smart. You know, we knew that, you know, hormones affect fibroids. We knew that there was a genetic predisposition to fibroids. We knew that there were factors that affected fibroids, but we really did not understand the roles that these different factors were playing. And we started breaking it down and realizing that there were tumor growth factors. You know, there was this extracellular matrix that was different than some other areas in the uterus. And we really started figuring out, hey, this is the reason why women develop fibroids. This is today. We're now going down to the cellular level. We're focusing, not only on genetic predispositions, but some of the mutations that are occurring with DNA and how certain aspects are affecting DNA replication. And we're getting a better understanding of some of the growth factors and how they play a role. So, we're learning more and more all the time, and this is spurring new thoughts and new ideas about how we can best, take care of patients and maybe even, break some of the factors that will lead someone to develop a fibroid. So I think we're all very familiar with risk factors. There's several of them, but by recognizing these risk factors, we can kind of individualize some of the treatment options that we can offer patients. And I think that that's one of the hallmarks of what I want to, drive home today with y'all, is that there are ways that we can impact fibroids besides just taking them out or treating them or suppressing them. So some of the data has validated some things that we've known about. We are recognizing that, some of it is, we've always known this, that, Black or African Americans have more fibroids. We're also validating the concept that their age of onset is younger. We've had some studies that have looked specifically at where folks were initially from. Nigerian descent seems to be the highest risk factor as far as genetics goes. But what's really interesting is we're starting to realize how many patients are going to have recurrence of their fibroids. And then, we're looking at other factors. We're dealing with an obesity crisis in this country. And we're seeing more fibroids than ever, and that's due to adipose tissue increasing some of these factors. Hypertension, probably not necessarily directly, but more indirectly. A lot more patients with hypertension have obesity, therefore they probably also have fibroids. And I don't think any of us are going to encourage our patients to smoke to keep their fibroids from growing. But that was one study that came out showing that the patients who did elect to use tobacco did have a decreased risk. Again, not sure a validated concept for management. So some of the things that have come out is, what are some of the factors that can lead to fibroid development? And I will tell you that the data is weak. When you look at some of these studies in details, there's some causation, association, but there really is not necessarily deep proof that this is the case. But, diet has been hypothesized. Gene just talked about, exposure to all sorts of things, plastics and PCBs and phthalates. And, these bring up questions about, is this exposure in utero, early childhood, and that's going to lead folks to develop a fibroid? Or is it more a cumulative effect over lifetime? Or maybe is it both? So this is an area that's being looked at. And then there's vitamin D that's been looked at pretty extensively. And there's been some data that's been published recently that shows that patients who took vitamin D really didn't have shrinkage of their fibroids, but they didn't grow compared to the patients who took the placebo. And it was a pretty small sample size, so I'm not going to lie to you and tell you that every patient that you see with a fibroid should also take vitamin D. There was another meta-analysis that looked at possible prevention of fibroids by utilizing vitamin D therapy. But I do think it brings up an important question, and that is, should we be screening all women for vitamin D deficiency as a tool to reduce the number that may develop fibroids? Or if someone comes into our office and they have a fibroid, should we include that as part of their workup? And so I think that's something that we have to kind of think about how that will play out in time. So this has been one of the biggest factors. We now have the entire genome sequenced for fibroids. One of the biggest mutations that we're seeing is the MED12 mutation. This is located on the X chromosome, the Q arm. And this is an area that's being researched pretty heavily. And part of what's interesting about this is we're starting to understand some of these mutations, but we're also starting to ask, can gene therapy become part of our repertoire for treating fibroids? Can we use CRISPR and maybe change some things? Can we develop tests that screen specifically for this type of mutation? And in those individuals that have it, offer them some additional therapy. We're also realizing that there's DNA translation issues that are occurring. This is spurring a whole new concept about bench therapy right now is looking at, can we use immunotherapy, similar to what's being utilized in cancer, to help prevent fibroids in high-risk individuals, or potentially slow the growth of fibroids for some patients. So I think it's innovative to think where things are going at this point in time. So I'm going to ask you to take what we're going to discuss about pregnancy and fibroids with a grain of salt. I think that a lot of the data that's been published recently is more generalized, saying either are 1, have a fibroid, or 0, you don't. It really does not take into account necessarily the size of the fibroid or the location of the fibroid when it's making these kind of generalized findings about how fibroids can affect pregnancy. But there has been some different thoughts than we've previously been taught. One of the things that we're seeing is that if someone waits until they're 30 or older for their first pregnancy, they're probably going to have more of an effect on their pregnancy from the fibroid than someone who develops a fibroid and say is 21. We thought that fibroids grew continuously during pregnancy, but we're actually finding that after the first trimester, they start shrinking. Now, we're going to play a little game here shortly talking about statistics and shrinkage, but we're actually seeing some studies that show on ultrasound fibroids are smaller at the time of delivery than they were sometimes prior to pregnancy. And we used to think that fibroids were absolute as a potential cause of infertility. We're now finding that that's typically with more than one fibroid, but a single fibroid alone. Again, size and location needs to be taken into consideration. Doesn't affect fertility as much as we once thought, in that spontaneous AB rates are similar to patients, both with and without fibroids. And this is one that when I read the study, I was like, maybe not, that there's no increased risk of premature rupture of membranes in patients who have fibroids. Take it with a grain of salt. I think we're getting a little bit smarter about some of these risk factors. Some studies that were published this last year looked at abruption, and basically, if placentation occurred over a fibroid, that risk was significantly increased. But if it occurred any other place in the uterus, that risk was not increased. And that preterm deliveries, we thought it was pretty much absolute throughout pregnancy, but now the data is pointing more towards not having a really increased risk prior to 28 weeks, but the highest risk is between 28 and 34 weeks. And some of these studies I think could be skewed by whether they were looking at patients that were being delivered for quote-unquote medical indications, or was it more social indications? So that's been one of the themes that showed up in several of these studies. We're all looking at ways of reducing C-section rates, and we recognize that in patients who have fibroids that their likelihood of C-sections is increased. But what we're seeing is we may be doing this ourselves. There's a lot of patients that may have had previous treatment for fibroids and were concerned about uterine rupture, or they basically are being told, I don't think you can have this baby vaginally because of your fibroids. But when we looked at the data, when patients that were having C-sections for like fetal distress or failure to progress or medically indicated reasons, that rate was not as high. So that's one of the things that I think we'll take away from this discussion today is just because there's a fibroid doesn't necessarily mean that we need to create a problem for a pregnancy. Another study that was pretty interesting was looking at postpartum hemorrhage risk. And what it showed was that a lot of the prior studies didn't take fibroids as an independent factor. A lot of these patients also had high BMIs or were, at advanced maternal age, and they were already at increased risk for postpartum hemorrhage. But the fibroids by itself may not increase that risk. And one that's really hitting everybody saying, is can myomectomy decrease the risk of a preterm delivery? If somebody delivered, say, at 32 weeks and you go in and do a myomectomy, are you going to reduce the risk of another preterm delivery? And some of this may not be the case. We may actually artificially be increasing the number of C-sections, from concerns about risk of uterine rupture and blood loss for some of these patients. So let's talk a little bit about medical management. There's, still the mainstay is estrogen, progesterone, or progesterone alone. Most of our insurers are going to require us to show that these have not worked for patients. We have to realize that they may work in about 1 out of 3 patients to reduce the amount of bleeding they have. And over time, that may diminish. Have they been tried on NSAIDs before they're going to approve other medications? But there's been a lot published about use of, TXA, both in reducing menstrual blood loss, menorrhagia, but also in utilization prior to incision at the time of surgery for myomectomy and hysterectomy. So that's panning out to show that it is effective. We've known about GnRH antagonists forever. Depolupron's been around as long as I have, I think. Kidding, but still, we knew that once patients came off of Depolupron, their fibroids regrew. Some recent studies show that the regrowth can be up to 24 months before it goes back close to the original size, and that was both true with either 6 months or 12 months of therapy. Okay, so I'm an academician. I teach residents, I teach medical students. So let's have a little quiz here. Ms. Jones has a 10-centimeter fibroid. You want to shrink. You're hoping for a 50% reduction in volume. How much can you expect the fibroid to shrink with treatment? So I'm going to ask for a show of hands. Who says number 1? Number 2? 3? Okay, 4? Not much. We have to think about that a lot of times we're thinking two-dimensional on ultrasound, and we're thinking about the fact that a fibroid is a certain diameter, and we need to be thinking three-dimensional, that these are spheres and there's a volume to it. And, the question is, do you still remember your 10th grade geometry? Are you ready to take the ACT again? But there is a formula, and thankfully a lot of our ultrasound machines are doing this for us. But again, it points out that even the ones that we're trying to shrink are going to have the least amount of impact with some of these medications. And so if you're using these medications to help shrink the size of the fibroid so that you can do a minimally invasive approach, you need to have some realistic expectations about how much it's going to shrink. I think that big game changer, and again, I may be biased because I did some research, some clinical trials with these medications, have been the GnRH antagonists. And I think that there's a lot of benefits to their use in that they typically do have less side effects. They're oral, they're easier to take. They have a very quick onset of action, sometimes in 48 to 72 hours, but they also have a very quick washout. So if patients are not doing well with them, they can stop them and get back to normal pretty quickly. But I think that there's a couple things we have to look at with these medications is that we now have limitations for how long we can use them. And in patients with fibroids, unlike patients with endometriosis, we're using higher doses, and these higher doses require add-back therapy. And this is mainly due to bone loss, but one of the things that we kind of are scratching our heads about with this is that there's a natural loss of bone density as folks mature. And the rates that we're seeing with these medications may be pretty close to that. And with discontinuation of these GnRH antagonists, there may be some reversal of this bone loss, but it's not going to go back to normal. But again, these folks are 2 years older than they used to be. And we also have to look at the fact that the trials for these medications, the Alaris trial for elagolix and the Liberty trial for relugolix, were both 24-month trials. They stopped them after 2 years. And because of that, the FDA is saying limitations of use is 2 years. But there's really some good studies that are going on right now that are looking at, can you reuse these medications? Could you use them for longer? So I think in the next several years, we'll have some answers around these medications. And then new drugs are being developed. There's Linzagolix, FDA trials are going on now. Folks have tried Cetrorelix. I think it's used in REI for suppression of premature ovulation. But there's a lot of clinical trials in the medical pharmaceutical worlds that are comparing specific GnRH antagonists against each other, and you can understand that there's probably a little competitive thought between the manufacturers. Is my drug better than your drug? One of the areas that's being looked at is, can we use these drugs in patients after surgery to prevent reoccurrence? We saw the number, we're going to talk a little bit about the number of patients that have reoccurrence after myomectomy. And also, can these drugs be used maybe to prevent the development of fibroids in patients who may be at high risk? And one of the ones I was involved in that's still ongoing right now is that, we know these drugs decrease estradiol levels, but do they provide birth control? Is it really necessary for patients to use barrier forms of birth control while on these medications? So we'll hopefully have an answer about that pretty soon. But that makes it difficult for some patients, to find good contraceptive options while taking these medications. And then we have the selective progesterone receptor modulators. There are some new ones that are coming out, but also we've learned a lot about some of the ones that we're familiar with. Mifepristone really works well for reducing bleeding, but really doesn't do a great job of shrinking fibroids. And it doesn't affect bone density, but it does increase likelihood of endometrial hyperplasia, and some patients, it can permanently increase their liver function tests. So we have to take that into consideration. And then ulipristal was really thought to be, hey, this could be the next game changer for medications. And it was about this close to FDA approval. And then in Europe, there was some questions that were raised about the fact that several patients that were on this long term developed liver failure, and some even required liver transplants. And so the FDA said, show us more data, show us some more longitudinal information. And in Europe, they suspended it back in March because of this risk. So this one's kind of, I think, playing out as not being a really great choice. But there are newer options. Valapristolin is being evaluated right now. It doesn't seem to have the same long-term effects. Very effective as far as reducing bleeding. And there's been some research looking at other medications, aromatase inhibitors. Some patients are just not good candidates for any kind of hormonal therapy, say because of breast cancer risk? And could letrozole be effective in reducing their bleeding? And there have been some small studies that show that it does result in some shrinkage and some symptomatic relief. It's very quick in onset of action, so can it be used to maybe stop bleeding in some patients till you can get them to surgery? That's being evaluated, and it's not a bad thought. Selective estrogen receptor modulators have had mixed results. And then, misoprostol or Cytotec is really not playing out very well as far as reducing bleeding or in reducing blood loss during surgery. So for a while there, we were looking at that as an option, but it's kind of shown not to be effective. Newer agents that are being looked at, there was a clinical trial at UC San Francisco and University of Mississippi looking at injecting, the collagenase into the fibroids, similar to what they do with, Dupuytren contractures of the hand or Peyronie disease or, syndrome, whatever you want to call it, in men. It did reduce pain. It softened the extracellular matrix, but it really did not have much effect otherwise, but that's going to be coming out pretty soon with some additional information. So one of the big areas that's being looked at is, what about medication use before going to surgery? And I think we have to realize that this is not something you can start the week before a patient goes to surgery. This is something that takes planning. It's usually going to take at least 3 months to get some significant results. And it's typically going to be a better option for improving, hemoglobin and reducing the risk of needing transfusion during surgery more than shrinkage. Controversial if it affects planes for your dissection for myomectomy. That's gone back and forth, and you get a bunch of myomectomy experts in a room and want to see a cage match, put them in the cage and ask them that question and see who comes out on top. Some things that have been found to be effective, TXA, of course we know about vasopressin. There's been some studies that have looked at injecting the cervix with lidocaine with epinephrine prior to hysteroscopic myomectomy that have shown some really good results. And then, the big question is, just like with endometriosis, is there a role for medical management after surgery? And can these, medications maybe help buy time for some patients before they develop new fibroids to replace the ones that we've already removed? So the question I get all the time, is there a role for hysterectomy still? You better believe it. It is our only definitive option. No uterine tissue, therefore no fibroids. But it is no longer our only option. We now have more and more technology that is coming out, and some of it's pretty innovative, and some of it's pretty cool. And more patients now are electing for more conservative management of their fibroids. Not everybody can take, several weeks off to recover from an abdominal surgery or a laparoscopic surgery. And a lot of patients are electing not to go definitive in their treatment. And we're seeing more patients that are desiring future fertility that already have fibroids in place. And we have to take all those things into account. But we also need to know how this new technology is comparing to older technology, I guess is the best way of putting it. And, we also are getting new data all the time about utilization of some of these older modalities of treatment. Myomectomy, we're looking at about a 27 to 60% recurrence rate. It does effectively reduce menorrhagia, but again, now new studies are questioning whether it does or does not improve fertility for patients. There was some concerns raised that patient outcomes with laparoscopic myomectomy were not equal to open myomectomy. Some of those studies were done with folks that were early in their learning curves. Further studies have come out here recently that validate that the laparoscopic approach is just as effective and may actually result in less complications, lower blood loss, but the OR times are definitely increased with the laparoscopic approach. Then the whole question is barbed suture as effective as normal suture and not tying. There was some folks that were saying there was an increased number of dead spaces that were noticed after myomectomy, which could increase the risk of rupture. There's been some validated studies that show that it's not the case and that actually decrease OR time and blood loss. Our old friend UAE, been around for a while. We've had a lot of controversy about this, especially in patients who desire future fertility. And I think that one of the things we have to look at is the way UAE was done initially and the way it's done now is different. Before, our radiology colleagues were using, using the gel matrices and occluding the uterine vessels, and it was having a global effect on the uterus. Now they're snaking those catheters up to the fibroids and injecting those microbeads or that matrix there. But it does have some effects, to myometrium, and we have to recognize that whether that's a smaller area or a global area, there's a big difference. Some recent studies have shown that patients who've had UAE do have diminished ovarian reserves. That's thought to be that some of this matrix that they use can affect blood supply to the ovaries. We're seeing that reintervention rates are higher than myomectomy and typically have to be done sooner than in patients who had myomectomy. And that although the conception rates are similar to myomectomy, miscarriage rates may be higher. Obstetrical complications are mixed. We have to realize that the myometrium is affected. That can affect, placentation. Some patients can have increased risks of placenta accreta spectrum, fetal growth restrictions, preterm labor. And a recent study from the UK shows that although some of our radiology colleagues are trying to promote this as being a better quality of life for patients than myomectomy, that didn't pan out, and the costs were actually higher. And NHS in Britain is not known for wanting to spend money, so they're kind of getting away from this. This is really not something that we see a lot here in Georgia, but it's something that our radiology colleagues are really pushing, especially in the Northeast. Is using focused ultrasound to basically treat the fibroids either with MRI guidance or ultrasound guidance. Problem is, it's not standing the test of time. Typically, these patients are requiring reintervention, and they may get some initial relief, but it may not last forever and ever. And they've had some pretty significant complications. There's case reports of liquefaction of the sciatic nerve. That's one that you don't bounce back from. So that's one, and skin burns from the ultrasound energy has been another one. But the fertility rates are not as good as myomectomy, but better than UAE, and it's not superior to UAE. This is one that I think is a game changer. And again, I may be biased because I do radiofrequency ablation, but this technology came out back in 2012. Some of y'all may recognize this as being the Assess Assist system from Hologic. This was the first generation. What's really remarkable is these ultrasound probes that we can use for these procedures. They are small and they really have great imaging. And on top of that, we get up close and personal to the fibroids. So a lot of times we're finding even more fibroids than we thought with transvaginal imaging. But we're able to specifically guide a probe into the fibroid for ablation. And this is the second generation. This is the system that I use called Sonata that is transcervical, that we can do this similar to hysteroscopy, and so this does not require as much anesthesia, and patients, I think, do better with this approach. It's not perfect for every fibroid. It's better for those that are submucosal or intramural, where the assessment may be better for those that have a subserosal fibroid. But it's really, interesting how we've been able to pair this really good visualization with ultrasound with, software that can predict the area that we're going to ablate. The red here is the ablation zone, and that's going to go up to 105 degrees Celsius. But this green area only goes up to 40 degrees Celsius. And what's really neat is you can see how small of a distance that is and how quickly that temperature drops off. And because of that, we can be very, very specific about our ablation zone. So I think that makes a difference. And the way this works is, going back to, when you were taught about your bovie and how it worked, we're using alternating currents, and it's causing the cations and the anions to go back and forth, and that creates friction, which generates heat. But this is monopolar technology. This is not bipolar. And so you have to dissipate this energy, and it's pretty high wattage. And so these patients need a lot of times 2 grounding pads to be able to disperse that energy. Works good for most fibroids. Unfortunately, when you think about it, if you have a fibroid that is on a stalk, that energy is going through that stalk, it's going to desiccate that stalk, and that fibroid's just going to be floating around either abdominally or in the endometrium, so we really can't treat those. But remarkable results with reduction of bleeding and reduction of size. These patients get back to normal very quickly. The main effect with the transcervical approach is just anesthetic wearing off. These patients really don't have much pain afterwards, unlike UAE, where these patients really do hurt from that ischemic effect. And it's a pretty low intervention rate. You can repeat the procedure more than once, and the complication rates are much, much lower for patients. So I think those are some additional advantages we're seeing with this. So one of the questions I get asked all the time is it approved for patients who desire future fertility? Right now, the answer is no. But 300 patients worldwide have gotten pregnant after this, and their outcomes have been similar to patients that have no intervention for their fibroids. And there's been no increased risks of pregnancy loss with it so far. There have been no uterine ruptures, no placenta accreta spectrum, no stillbirths, and no growth restrictions. So I think, this is just my personal opinion. It's probably going to take about 1,000 patients who have a pregnancy after these procedures before the FDA is going to say, yep, it's cleared for patients with future fertility. But I think when that does happen, this could replace myomectomy as the gold standard for patients that desire future fertility. It's less invasive, the recurrence rates don't seem to be the same as with myomectomy, and we're not seeing the risk of uterine rupture from scar tissue dehiscing after the procedure. In China, they're looking at ultrasound-guided microwave energy. This is similar to what's being used to treat solid tumors in the liver or adrenals or thyroids. They claim they can ablate a larger fibroid with this technology, but there's been no pregnancy data, and a comparison study to UAE showed it was not superior. Okay, so that's kind of, a summary of everything. There's more research than ever. I think we're going to continue to see increasing amounts of research about our old friends, the fibroids. I think they're getting more attention than they ever have before. More and more patients are saying, I shouldn't have to put up with, having, these horrific periods. And I think we're going to see a lot of innovation coming down the pike on how we can prevent fibroids, but also how genetics is going to play into this and how we may be able to alter some of these risk factors. We're going to see more data coming out about pregnancy and fibroids, and more treatment options are going to start appearing. There's some really neat technology that Silicon Valley and some other areas are putting together right now. I think in the near future, things for you to watch out for is increased information about the effectiveness and utilization options for GnRH antagonists. We're going to see some new drugs that are probably going to come out. We're going to see more data about utilizing these medications to take patients to surgery and after surgery, and more comparative studies about their effectiveness, saying one versus the other, and then whether or not RFA is going to pan out to patients who desire future fertility. All right, these are my references. If you would like more details, or if you just need something to help you fall asleep at night, there's a lot. And I want to thank you all for the opportunity to share this information with you. Please don't forget your sunscreen when you go out to the beach today. And with that, I'll take any questions that y'all have.
Dr. Betcher, thank you for a wonderful presentation. Keisha Callens, OBGyn from the Macon area. Just a quick question. We do have a mutual patient. Any updates regarding the management of prolapsed fibroids? We talked about a lot of new things today, and do you have any advice for us regarding that?
That is one of those fibroids that is always difficult to manage. Our first thought is hysterectomy. We need to, take this fibroid and the uterus out. But, we can be very selective in how we approach it. I think there's been a lot of good discussions, like within AAGL, about combined approaches with hysteroscopic approach with ultrasound to be able to identify stalks and be able to sometimes shave these fibroids down. RFA has not been applied because a lot of these are on stalks, and we end up, liquefying the stalk itself without necessarily treating the fibroid. But it is one of those ones that does take a little finesse. We sometimes find ourselves getting pretty inventive in the minimally invasive world, and it's amazing that you can take an endoloop and sometimes snake that around that fibroid and up and ligate. There's opportunities to hysteroscopically shave them down and to be able to get better access to the rest of the endometrial cavity, things like that. Right. But I'm not aware of any new studies that have published anything about the best way to approach those other than what we've traditionally done.
Okay, perfect. Thank you so much.